Welcome, and thank you for joining the joint co-sponsored briefing on addressing the Latino physician shortage, co-sponsored by the California Initiative for Health Equity and Action in the Latino Policy and Politics Initiative. We're really excited to present a really packed agenda full of information today, focused on a major priority for our state. We know that Latinos increasingly represent the majority in California, and yet we are underrepresented in most health professions, in particular physicians. Today, we will be having a full agenda, starting with Jeff Oxendine from UC Berkeley, who co-led the California Future Physician Workforce, who will be talking about physician workforce diversity recommendations. Then we'll dive right into Dr. Anaya from UCLA on solving the Latino physician shortage, and she'll present excellent data on trends. Next, we will talk about how to support Latino physicians in practice by expanding coverage to undocumented Californians. So we'll cover the various policy solutions to expand coverage, and Dr. Vargas Bustamante from UCLA will be covering that. Next, we have Dr. Marlene Martin, who's a hospitalist at UCSF, who'll be covering addressing ethical tensions for Latino physicians in practice. As you know, COVID-19 has disproportionately affected Latino patients, and Dr. Martin has frontline experiences that she'll be talking about. We'll then finalize the briefing with a facilitated question and answer from Mr. Jeff Oxendine again, who will facilitate discussion of policy solutions among the panel. In terms of our sponsorship, generally as the California Initiative for Health Equity and Action, as part of our briefings, we generally host you all in the Capitol and provide food and beverages. And because we're not able to do that, we want to give that support to a worthy organization. And we selected Mi Mentor, given the topic today. Mi Mentor is a very innovative national mentorship organization committed to mentoring the next generation of healthcare professionals. And their mission is to support and develop inclusive and innovative mentorship opportunities that will inspire the next generation of healthcare leaders. So we'd like to make a plug for them. You'll also notice in your packet with this meeting that there's several organizations listed that you can donate to with the mission of expanding physician workforce and particularly diversification of the workforce. With that, I will transition to Mr. Jeff Oxendine, who will lead us through the California Future Workforce Commission's diversity recommendations.
Good afternoon, everyone. It's really a privilege to be part of this webinar. Despite what's happening in our country and our state right now, it's still important to invest in strategies to build the future workforce, particularly to address the Latino physician shortages. This is not a new topic. It's something that has been discussed for years, and we have a long way to go, but we're not starting from scratch. I'm going to talk about some of the recommendations from the California Future Health Workforce Commission that were completed last year that are directly related to this topic. To start out with, I think we all know that unfortunately Latinos, African Americans, Native Americans are severely underrepresented in the health professions, particularly around physicians and other clinical professionals. This was one of the key themes that the California Future Health Workforce Commission tackled. The commission was co-chaired by Janet Napolitano, the president of the UC system, and Lloyd Dean, the president of Dignity Health, and had a really senior leader group of people from labor, from academia, from private industry, from government to come up with what the solutions were, and came out with a total of 27 recommendations, of which 10 were top priority. And of those, multiple of the top 10 were focused on building the future physician workforce and diversifying that. We had three core strategies from the commission. The first is to increase opportunity for people from all California communities to become future physicians and other future health professionals. And this includes health and public health, mental health, older adult care. But we really have the rich diversity. We have the talent, the knowledge in our communities. We just have to give people the opportunity to do that. The second is to have the educational capacity once people are interested in and competitive candidates to be able to have the educational capacity to produce enough people graduating from medical school, completing residencies, being able to go to work in our communities, and finally to leverage the people we have most effectively. I'm going to focus on strategies 1 and 2 today. Within those strategies, one area that was particularly important, one of the top 10 recommendations, was to increase the scholarships for qualified students who are from our local communities in California who would commit to serving in their communities after completing their education, but to give them a scholarship on the front end. We've done a good job in our state of investing in loan repayment for practitioners, which is really important. But we feel that many people from our communities have barriers of even being able to choose to go into a particular profession, to choose to go to medical school, and to be able to, because they're afraid of the debt that's involved with that. So providing a scholarship in return for service on the front end would be critical. And we projected that 1,700 new providers would be developed through this program. We also have to want to expand the PRIME program, medical education. We know the PRIME has a proven track record of producing a greater diversity of graduates who go into primary care, who go into practice in our communities. And so investing in those programs and expanding those programs is critical. Also increasing residencies. California has is number 1 in the country of people completing their residencies and then staying in the state to practice. The 2 biggest determinants of where people practice are where they're from and where they did their residency. So increasing the number of residencies along with increasing the medical school capacity is a way to really get more people from our communities to return and serve in their areas. A big focus we had was supporting people from rural and urban underserved areas who may not always have the direct pathway into medical school. So there's a new program, particularly run by UC Davis, to help recruit people from rural communities, underserved urban communities, give them a scholarship, give them some additional support and some different preferential in the admissions process to be able to do that. So those are 4. Another of the recommendations from the commission was to scale and sustain proven health pathway programs in our state. And we're fortunate, we have some of the strongest health pathway programs starting at K through 12, all the way through college and post-bac to support students from our communities to become health professionals. We highlighted Me Mentor earlier, but we have a number that are already there, that many of them have been doing it for 20, 30 years, but are always struggling for funding. And so sustaining, scaling them, is at this time would be critical to produce more physician leaders from our community. At the same time, we have various statewide and regional programs that also are in place to invest in those programs and being able to scale and sustain them. A lot of the work in California needs to be local, where our population is based. So being able to reach people as early as possible, supporting them all the way through their return to serving is critical. And getting health plans and others to invest is a big part of it. We had a health career opportunity program recommendation. We already had a proven health career opportunity program for many years and federally, but this would be to create a statewide health career opportunity program and support existing HCOP programs, but create HCOP programs at CSU, UC, and private campuses, as well as the community colleges, because I think we need to support students at all of those levels. There's rich diversity, there's talent at those levels. We need to get them beyond those places with support academically, career-wise, psychosocially, and advising to go to that next level. And these programs have a proven track record of getting people into becoming physicians and would produce 25,000 new underrepresented professionals. Finally, investing in post-bac programs are also a really good return on investment and something that's really needed at this time. And then continuing to support loan repayment programs and medical school expansion, which are under fire right now in the new budget. So very important that we still take action to support those programs. The return on investment from all of these recommendations that the commission came up with, actually the top 10 would be dramatic for our state in terms of increasing the number of Latino and other underrepresented providers, which we really need to serve our growing population, and the added number of people who are going to be on Medi-Cal now are underinsured. Well, I'll leave you with a final example of this works, because a lot of people feel, well, this is a daunting challenge. We have great programs, but does this really work? And here's an example of Dr. Evita Limon Roca who came from the Inland Empire in Reach Out West End's program, was part of Health Career Connection that I run. She ended up saying, I want to go back and serve my community. And so she went on to the Prime program at UCLA, residency at Irvine. She became the resident of the year last year for the National Hispanic Medical Association. She has now returned to serve the Inland Empire as a child and adolescent psychiatrist, really needed, bilingual, and is also a policy champion. So we know that it works, but we have to invest in programs to make that happen and increase their scale. So with that, we'll turn it over to our next presenter.
Thank you. And as a reminder to the audience, if you have questions for our presenters, please do include them in the chat. And we will be going through the chat at the end, and Jeff will facilitate a discussion and response of those questions in the chat. So please, we do want to hear from you, and thank you for making those contributions. I have the pleasure of introducing Dr. Yoali Valderas Medina Anaya, who is Assistant Clinical Professor and Family Physician at the UCLA Geffen School of Medicine. She holds an MD and an MPH from the University of Southern California, and her background is that she immigrated to Southern California from Mexico at the age of 4, and her background has deeply shaped her goals as a physician. She is passionate about improving health and healthcare for the underserved by utilizing innovative public health programs, advocacy, and public policy aimed at improving physician workforce diversity, and all of this in order to achieve health equity for all. Thank you, Dr. Anaya.
Thank you so much for having me. It's a true honor to be here. So let me pull up my slides here. All right. So, full disclosure, addressing, let alone solving the Latino physician shortage is not something that I'm going to be able to hash out in the short time that we have for this presentation. But I do hope to leave you with a framework with which to begin to amplify that conversation. The Association of American Medical Colleges, or AMC, predicts that the United States is going to see a shortage of up to nearly 122,000 physicians by 2032. And the Workforce Commission has estimated that approximately 7 million Californians live in a health professional shortage area. This includes some of the state's largest and fastest growing regions, such as LA, the Central Valley, Inland Empire. And Latinos and African Americans and Native Americans are the majority of residents in areas with a physician shortage. So our physician shortage is particularly acute in areas in need of primary care providers that can deliver language concordant care. And in the next couple of slides, we'll review the severity and the depth of the physician shortage, and more specifically with regards to Spanish-speaking and Latino physicians. And at the end, I'll leave you with the 3 main takeaways from the dense but brief talk. But why does this matter? Latino physicians are more likely to serve often neglected populations. The shortage of Latinos in the physician pipeline significantly reduces the pool of physicians that are likely to practice in medically underserved areas and that are going to treat patients of color. In addition, previous research does show that racial and ethnic concordance between patient and provider is associated with improved health outcomes. So first, let's look at the medical school stage. The racial and ethnic composition of medical school graduates in California differs from the population demographics in California. In this study, we compared the 2016 California population estimates from the Census Bureau with the medical student graduate data from the AAMC. This figure shows the share of medical school graduates by race and ethnicity from California medical schools for the academic year of 2016 to 2017, and the corresponding race and ethnic composition of California's population. So if I can draw your eyes here to the baby blue, Latinos make up 40% of the California population, but just barely over 11% of MD graduates in California. The disparity is going to grow if we don't take some action soon. So now let's look at the next stage of training, which is residency. In this study, we looked at the ratio of Latino resident physicians in relation to the Latino population in 4 states that have some of the largest Latino populations in the country: California, Florida, New York, and Texas. We found that California has the worst Latino resident physician shortage among these states, and that the rate of physicians in the training workforce has largely remained stagnant over time, as you can see here in this red line. We found that California only had 5.4 Latino physicians in the training workforce per 100,000 Latino population. For comparison, the national average is 36.5 residents per 100,000 population in that same year. This comes out to 85% lower than the national average. California is followed by Texas, Florida, and New York actually demonstrates the highest rates of Latino residents in the training workforce, but this is still about 22% lower than the national average. So how well does our physician workforce meet the linguistic needs of our patient population? There's ample literature exemplifying the disparities that arise when patients do not share the same language as their physicians. Ensuring care that is responsive to language needs as well as respectful of cultural values is recognized by the Institute of Medicine as a fundamental component of patient-centered care and ultimately of healthcare quality. So in California, 19% of the total state population can be categorized as limited English proficient or LEP, and that can have effects on patient health status, access to care, health outcomes, patient safety. And after English, Spanish is the most spoken language in California. According to the Census Bureau, well over 10.5 million residents in California speak Spanish. But as you can see here, it's clear that some languages, those here on the left, are well represented in California's physician workforce: Farsi, Hindi, Korean, Chinese. But what's concerning is that Spanish-speaking physicians are the most underrepresented at about 62 physicians per 100,000 Spanish-speaking individuals, in comparison to the baseline rate of 344 who speak English for the population. So optimally meeting the language needs of our patients, it goes beyond just offering an interpreter. More needs to be done to address these shortages if we really are committed to providing safe, equitable, and patient-centered care. So the last set of study findings I want to share with you are those to help demonstrate the gravity of the Latino physician shortage that we're facing. By 2050, Latinos are estimated to become about 44% of the state's population. And at the same time, Latino physicians in California, that scarcity has led to a deficit of over 54,000 Latino physicians that would be required to reach parity with non-Latino whites. Importantly, I will say this estimate does assume perfect parity between Latino physicians and patients, and in practice, a diversity of providers should be delivering care to a diversity of patients. But just to look at the numbers for strict comparison purposes, the Latino physician rate is nearly 90% lower than the non-Hispanic white rate in California. There are only 45.8 Latino physicians for every 100,000 Latino Californians, in comparison to the physician rate of 405 for non-Hispanic whites per 100,000 population. So here you can kind of see, this is just an example of how different medical schools in California fare in terms of their representation of underrepresented minorities and specifically Latinos. I will say that, there's definitely some schools that are doing a relatively good job, like UC Davis, UC Riverside, and then there are others that aren't quite as so. Specifically for the UCs, I would say that generally we do tend to have a higher rate of Latinos in our population, in our student population. So the amount of time that it's going to take to reach parity is actually, it will take up to 5 centuries. At California's current Latino MD graduation rate, it would take these 5 centuries to reach the Latino physician shortage that we had for 2015. Even if the number were tripled, the number of graduates were tripled, reaching parity wouldn't occur until the year 2184. And here, this really demonstrates the magnitude of the Latino physician shortage. So some policy solutions. The capacity to integrate the state's plurality into the medical profession is critical to close the healthcare workforce gaps. If the physician workforce is unable to speak the primary language of patients and navigate through cultural nuances, commit to practicing in medically underserved communities, their ability to treat patients is imperiled. This undermines the provision of quality healthcare services for all, and it really does prevent a critical public health concern. Reducing the impact of the California Latino physician shortage is going to require tailored policy interventions with both short-term and long-term outcomes. So according to prior research by LPPI and Dr. Arturo Bustamante that you're going to hear from shortly, URM students who are interested in medicine encounter socioeconomic and academic disadvantages, challenges in navigation of higher education, underrepresentation, and citizenship issues. Research shows that these barriers are contributing to a leaky pipeline. And as someone who works with students along that leaky pipeline, I can tell you that in addition, what Jeff was mentioning, the importance of easing the financial burden of students, that's their number one concern. But from the educator standpoint, I can also say that it's just as important to address the academic and structural disadvantages that they are facing. And so we can do this by expanding pipeline programs and really supporting these pipeline programs that are recruiting and preparing students from underrepresented and low income backgrounds. They provide opportunities, and ideally, we should be funding their systematic evaluation. We should be collecting and disseminating those best practices so that we can further develop these programs. Jeff mentioned programs that we have throughout the state. Even just here at UCLA, we have MedPep, the Family Medicine Bridging the Gap Pipeline Program, the Summer Urban Health Fellowship over at Harbor, and they're all working hard to prepare our URM students to succeed, and programs like this need to be supported. To this end, we can also pursue institutional partnerships that are going to provide academic support and supportive advising, note the word supportive, for students that are in our community colleges, CSUs, and UCs. Many of our students don't have access to truly supportive advising, and those of us who've been privileged to have pre-med advisors and mentors that were truly invested in us can really attest to the power of their support. In terms of, with regards to increasing the recruitment of these students and residents, there's a couple things that I want to bring to your attention. First, we need to protect the ability of current physicians, medical students, and residents that depend on DACA. We need to truly advocate against the termination of DACA and really ultimately advocate for more permanent solutions for these health professionals who are already on our front lines. At the medical school level, we need to ensure medical schools continue to consider students for admission, regardless of undocumented or DACA status. We need to incentivize medical schools to prioritize the matriculation of linguistically capable students and students interested in primary care in underserved areas. Then we need to actually ensure their success once they've matriculated. Again, this means appropriate financial aid and academic support for these students that are traditionally disadvantaged. At the residency level, I want to point out, so specifically at California, currently we're facing the chopping block with the Song-Brown Physician Training Program. And this program provides funding for primary care residency programs that already have a proven track record of serving underserved populations and graduating physicians who remain in underserved areas practicing primary care. The governor's budget proposes to cut funding by more than 90% to the Song-Brown program, and we can ill afford these cuts during a healthcare crisis. So finally, we need to incentivize practice in linguistically underserved regions. We could consider instituting a health professional shortage area designation specifically for language gap areas, and then incentivize bilingual trainees and physicians to practice in these language gap areas in a variety of ways. In order to effectively attract medical students to primary care, we have to consider how to improve conditions for our primary care docs that are out in practice and make primary care careers more desirable for our students. Income disparities exist for certain racial ethnic groups such as Latinos, and improved compensation will likely attract more students facing high educational loan burden. Furthermore, developing sustainable practice environments for clinicians is truly critical. Primary care physicians have to have the support to practice effectively, and especially so within underserved areas. And finally, we need to consider to expand the existing pool of linguistically capable or Spanish-speaking IMGs. In California, we can achieve this by supporting existing IMG programs like the UCLA IMG program that bolster match competitiveness and prepare them for admission for residency programs in primary care in exchange for actual time practicing in an underserved area upon the completion of the residency program. Funding should be allocated to support these programs that already have demonstrated success. So if you remember three things from today's very dense presentation, is that one, the underrepresentation of Latinos in medicine exists at multiple levels and at very concerning levels. In the short term, what we can do for our workforce that will reap more immediate benefits is protecting DACA. The pandemic has underscored the need for DACA in a very tangible way, but I would suggest to you that even outside the pandemic, the workforce is truly one that we can't afford to lose. Undocumented students are almost all fluent in 2 languages and nearly all interested in working in an underserved community. We have to protect DACA and ensure the support of undocumented students at California public colleges and universities. And more importantly, we must advocate for onboarding this critical workforce into our society in a more permanent way. Our healthcare system and our patient population has extensive reliance on these 27,000 DACA health professionals that are currently on the front lines amidst the pandemic. In terms of long-term solutions, what we can do is really support the pipeline of students before they fall through the cracks. Research really shows the interest for health careers is actually already there amongst our students. What we need to address are the barriers that they're encountering along the way, and supporting and funding programs that provide them the academic preparation and competitiveness to make it in and then succeed once they're there is going to be paramount. So now more than ever, we really need a diverse medical workforce. And so with gratitude, I want to express my gratitude to CESLAC and the LPPI and our amazing research team for making this research possible so that we could share this information with you, to Kalahea for co-hosting this event with us, and ultimately, really to the many advocates who have been working on this long before my generation made it to medical school, and who we could argue are really the reason that myself and other colleagues are out in the trenches doing this work today. So truly thank you to all of you, and thank you for giving me your time today.
Thank you, Dr. Anaya, for that excellent presentation. I'm sure you generated a lot of questions. Again, we encourage you to put your questions in the chat. Next up, I'm going to ask Dr. Vargas Bustamante to pull up his slides, and while he's doing that, I'll introduce him. Professor Arturo Vargas Bustamante is Professor of Health Policy and Management at the UCLA Fielding School of Public Health. He has a broad background in healthcare policy with specific training and expertise in healthcare survey research and data analysis, healthcare cost estimation, economic evaluation, and program evaluation. His research investigates unexplored or underexplored topics on healthcare access, predominantly among Latinos and immigrants in the United States. He has over a decade of experience researching access to care among undocumented in California. He is a Golden Bear. Will take credit for his success at UC Berkeley. He holds a PhD in public policy from UC Berkeley, as well as a master's in economics and master's in public policy from Berkeley. Thank you, Dr. Vargas Bustamante, for your time presenting to us.
Thank you, Hector, for the invitation to talk today about how to expand healthcare coverage to undocumented immigrants. And thank you for all the panelists for this joint briefing, hopefully the first of many between Kalahea and LPPI. And also to all of you who are connected right now, who are interested on how to deliver healthcare to vulnerable populations. This research was sponsored by Kalahea, and the main purpose of this presentation today is just to summarize what are the main findings of this policy toolkit. I will include a slide where you are going to be able to get full access to this policy toolkit, and there you will definitely identify some of the detail that I will just have to talk very, very rapidly today, just in the interest of time. So today's quick talk is gonna provide you first with some background on the access to care challenges that undocumented immigrants face in California and in the US. And then I'm gonna present you policy options on how to address these challenges. This toolkit focused primarily on options that were geared towards state and local authorities. This policy toolkit essentially assumed that the federal inaction will continue to be the place in the next few years. However, the need to provide healthcare to the undocumented is there, and communities, local authorities, state authorities have to deal with the problem more directly. So then At that level is where we will find solutions on how to deliver healthcare to the undocumented. So I'm going to be first talking about the different state initiatives that could be considered to offer health services to the undocumented. And then I'm going to introduce you the local and community initiatives on how to do this at the local level. I'm sure that many of you are already familiar with the characteristics of the undocumented in the US. However, I just want to point out to the composition of undocumented immigrants showing this graph. Number one, because it shows that almost 2/3 of the undocumented population in the US is Latino, meaning that these undocumented immigrants come from Mexico, Central America, and other Latin American countries. So what is the problem in how to deliver healthcare to the undocumented? Well, number one is that the undocumented immigrants are ineligible to enroll in any federally ACA-sponsored program, meaning that the federal government will not provide services for them to get enrolled into a Medicaid program or in one of the exchanges. Even though some federal funds have been assigned to increasing funding for the safety net for FQHCs, this is clearly insufficient to provide comprehensive healthcare to the undocumented. So what is the situation? Why is this a big problem? Well, because too many undocumented immigrants lack health insurance and access to care, leading to situations where healthcare is delayed, it's more expensive to get access to healthcare, and when conditions advance unattended, many undocumented immigrants end up in the emergency room, where it's much more expensive and many times even much more invasive to treat with these conditions. And more recently, we are dealing with new public charge regulations that will make access to healthcare even more challenging, because these regulations are essentially going to discourage access to care, not only among the undocumented, but also among those documented immigrants who are not yet citizens or who are in the process of getting a green card. So if present trends continue, undocumented adults will face increasing access to care barriers in California and in the US. To provide some basic figures to show the disparity and health inequities that undocumented immigrants face in the US healthcare system, I just want to show this graph. Yes, the ACA has been an incredibly good legislation in the sense that it has reduced considerably the number of the uninsured population in the US. However, when we see who are the ones who are still uninsured, here you can see that while only 8% of the uninsured are US citizens, almost 45% of the uninsured are undocumented immigrants. And lacking health insurance coverage obviously looks reflected in healthcare utilization and preventive healthcare, primary care. And in this graph, you can see that those who have responded to a survey on a usual source of care other than the emergency department by citizenship and immigration status, there's a disparity between US-born citizens that are almost 76% of US citizens have a usual source of care, compared to only 61% of the undocumented who have a usual source of care. So what are the policy options? As I mentioned in the introduction today, this policy toolkit assumes federal inaction, meaning that not much is going to change at the federal level. Even if there's a change in the administration, it's unlikely that there will be a political consensus at the federal level that would change dramatically that types of rules that apply to undocumented immigrants' access to healthcare. So what can be done at the state and the local level? So this policy toolkit look in depth at all the different programs that have been implemented in California, in other states like New York, where some policies using state resources have been trying to increase healthcare coverage, if not comparable to that type of coverage that is available through the ACA, but to supplement or improve the type of care that is delivered to the undocumented. So to identify policy options to expand coverage to this population, we examined, number one, innovations at the state and local level. Number two, we selected cases to identify best practices. And number three, we identified lessons and useful resources. This is the first figure in this policy toolkit when we plot the different policy options based on cost effectiveness and coverage. In this axis, you can see that while the coverage that could be from very basic coverage to very advanced coverage, and cost effectiveness from less cost effective to more cost effective. So this is like a menu that state governments could consider to identify some political consensus and taking into account political realities and economic realities at the state level to see which type of policy could potentially be useful at that state level. So here you can see while emergency Medicaid is at least a humanitarian way of addressing healthcare needs of the undocumented, is definitely not very cost effective because, as I mentioned before, the undocumented get very advanced stages of disease, and many times they cannot pay for these services. While in the case of kidney transplants, of insurance or comprehensive insurance coverage is a much better way of getting healthcare and of saving money at the state level. Why kidney transplants could be a more cost-effective solution than dialysis? Because these two solutions, that emergency and skilled dialysis, will represent a higher cost at the state level and at the emergency department level. Another type of plan that could be considered at the state or at the local level are creating medical homes with county services. Here you can see the detail of 3 different plans that we analyze in this policy toolkit: Healthy San Francisco, My Health LA, and New York City Care. All of these medical homes have, or healthcare plans have different types of eligibility. Each one of them has different more payment mechanisms, and all of them have different benefits and provisions. That essentially gives different menu option for different county, local, and state level to consider transforming and improving the services that are available to the undocumented. So this is the second graph that I want to show you today, that are the policy options that we discussed in the policy toolkit at the local level. Again, they are plotted based on coverage and cost effectiveness. And here you can see, again, insurance, providing comprehensive insurance is always the more cost-effective and advanced form of coverage, but we realize that it's many times unaffordable for many states. While in California, it has been the case that Medicaid eligibility has been provided to undocumented young adults. This is probably not going to be feasible in other states. However, there's other options such as medical home, counties and community clinics, public health solutions, and collaborations with community organizations providing outreach or very basic chronic disease management that could improve at least a little bit the type of services that currently the undocumented have access to. So what can we conclude from this presentation? Well, number one is that state and local governments can definitely expand coverage to the undocumented. And number two, that there are options. And I want to offer you the possibility of taking a look at these options by going to this URL that is available at CALA here, where we provide more detail on how to deliver options, policy, better healthcare to the undocumented. So with this, I will stop sharing my screen and take from here to the next speaker.
Excellent. Thank you, Dr. Vargas Bustamante. I wanted to underscore the importance of the topic of improving coverage to improve the workplace conditions and the working environments of Latino physicians. Next, we have Dr. Marlene Martin, who's an assistant professor and a hospitalist at the UCSF School of Medicine and Zuckerberg San Francisco General Hospital. She's driven to improve care for vulnerable populations with a safety net. Drawn to medicine to address health inequities and social injustices, her interests focus on care transitions and addiction medicine. Dr. Martin was born and raised in LA, and as a first-generation college graduate, she attended college and medical school at Stanford and was an NIH Fogarty Scholar in Peru. She's bilingual and bicultural, Mexican background, and this really influenced her desire to serve underserved populations. Thank you, Dr. Martin, for taking it away.
Thank you so much for having me. I'm really happy to be part of this panel because I am very driven to expand the physician Latinx shortage. And I think one of the topics that really elucidates why this is important is what I'm going to be focusing on, which is addressing ethical tensions for Latinx physicians, moving beyond clinical care to focus on advocacy. I know that my path to medicine is really driven by my background as a daughter of Mexican immigrants, and that I chose to work intentionally at San Francisco General, where I can care for vulnerable patient populations. And many of us who come from diverse minority backgrounds go back and serve the communities that where we come from. And so this topic is very important. So I'm going to be focusing my conversation around Latinx individuals and COVID-19. As you have all been very aware acutely, many communities of color, and especially Latinx communities, have been disproportionately impacted by COVID-19. So I'm going to focus on Mr. R. Mr. R is a patient, one of my first patients that I admitted with COVID to San Francisco General. He's a 40-year-old Spanish-speaking man who'd been having symptoms at home for a couple of days, and he presented and had COVID. During our conversation, when I was admitting him, I learned that he was employed as a roofer, but he'd been laid off a few days before falling ill. His wife worked as a babysitter, but she had not been working since shelter in place. He lived in a small apartment with his wife, where they shared the apartment with another couple and the couple's children, and they shared one bathroom between all of them. And as the weeks went on, I noticed that it really just wasn't Mr. R who was presenting with similar themes and risk factors. It really was about 80% of the people who were being hospitalized with COVID in my hospital were Latinx. And I was acutely aware of this because normally the Latinx population makes up 30% of the people who are admitted to the hospital. We make up 15% of San Francisco. So it's just it was really in disbelief, knowing that these are my patients who are coming to the hospital, and knowing that so much more needs to be done in the community. And so this for me was an ethical tension where I was seeing, there's a lack of I felt like there was a lack of response in the media and from systems approaches to thinking about solutions. So I'm going to be using the 5 A's framework as a guide for how to think about ethical tensions. This framework comes from the National Academy of Sciences, Engineering, and Medicine, and it's been applied as a way to think about how to integrate social care into the delivery of healthcare. The main things that I'm going to be using on here are awareness, alignment, and advocacy. I think of awareness as figuring out what the social risks are, what are the inequities that are happening, being aware and learning more about them. I think of alignment as getting together with all the different stakeholders and getting on the same page about the topic, and then advocacy as moving towards action. So to start off with awareness, the recurring themes that I saw coming up for my patients as more and more of them were admitted, I saw that they were sharing living spaces in small quarters, both due to financial reasons and partly culturally, to live with multiple generations in the home. Just traditionally, I saw that my patients were low-wage workers and essential workers. They were taking public transportation, they faced food insecurity, and they also had limited healthcare access. And this goes beyond just having a primary care provider or insurance. This also was fear of accessing healthcare and getting tested. What are the implications of a positive test? What does this mean in terms of immigrations and customs enforcement, especially with so much anti-immigrant sentiment that has been happening recently? And there's so much also misinformation about public charge, and does that apply to me, and what will there be repercussions later due to accessing healthcare? So to build on creating more awareness, taking a look at some of the data that helps guide us as to why this is happening, we see that Latinx individuals are overrepresented in occupations where they are earning lower wages and also where they are essential workers who make shelter in place possible for more comfortable and possible for so many others. This includes food and farming industries, environmental services, construction, and transportation and production. We also see that Latinx individuals are more likely to be uninsured. They actually face the highest rates of uninsurance among any racial or ethnic group in this country. So 25% of Latinx individuals are uninsured. When you look at foreign-born individuals who are Latinx individuals who are uninsured, that number goes up to 40%, and it increases to 50% when you look at documentation status. So based on what we were seeing in the hospital and what was happening in our community, a couple of us got together to try to raise awareness and also create advocacy and a call to action. We published a piece in the local newspaper, an op-ed that was focused on, highlighting some of the things that I just talked about in terms of people being essential workers, not having a choice not to work, as well as presented possible solutions of this call to action, focusing on making sure people have accessible access to tests, to make sure that when somebody does test positive, that there are resources that go with that there's support for these individuals, including access to healthcare. And then thirdly, to ensure that there's language concordant information that's being distributed to our communities that are being disproportionately impacted. This call to action was heeded by a group of individuals in San Francisco. This included community-based organizations who were already forming and had formed a Latinx task force. They were originally focused on dealing sort of with the disproportionate economic impacts they expected for Latinx individuals. And when they heard that COVID was actually disproportionately directly affecting Latinx individuals, they really wanted to be part. They were already working on being part of the solution. So they worked together with the San Francisco Department of Public Health and then a group of UCSF researchers and healthcare workers to come up with a study that was done in the Mission neighborhood of San Francisco. This area is the second densest area in San Francisco and also has a lot of Latinx individuals. And what they found was that 95% of the people who tested positive for COVID in this community are Latinx. And of those individuals, 90% had no choice but to go outside to work, and 89% made less than $50,000 per year. As a result of this alignment of the different stakeholders and this study, so much positivity came from it. There was a huge push for advocacy by partnering with the district supervisor in this neighborhood. They focused on contact tracing, and there was trust that had been built based on this study. And because the community-based organizations were really the ones driving a lot of this. And then for people who tested positive, there was support that came. It included food, supplies, access to healthcare through the Department of Public Health system, and then monitoring for those patients. And thanks to this, there's actually duplicate efforts ongoing to help spread this effort in other parts of the city where we know that there's other communities that are being disproportionately impacted. And these efforts, the clinical testing efforts, are being led by Dr. Karina Marquez, who is a Latinx physician. I wanted to show this graphic because it really nicely elucidates all the different health disparities due to COVID and also all the possible solutions. And unfortunately, we know that the disparities are not just affecting Latinx individuals. This is affecting other communities of color, including Black communities, Native American communities, people who are experiencing homelessness, and people with substance use disorders. And when we think about Latinx individuals and apply this graphic, we see that, we talked about access to care being one of the risk factors, and socioeconomic status. And then when we look at the solutions that were done through the alignment of the community-based organizations, Department of Public Health, and the researchers, we saw that food, access to healthcare coverage, and expanded and easily accessible testing were part of the solution. So I'd like to come back to the framework that I applied here And that helps guide me whenever I think of a care gap, an ethical tension, and I want to move from clinical care to advocacy. First and foremost, I really focusing on making sure that I'm providing excellent care to my patients, being really aware of what the reality is for my patients and identifying the inequities, and then bringing together all the different people who are involved and exploring why with the stakeholders, and then coming up with solutions and advocacy. And there are so many opportunities for Latinx individuals because this is not just happening in COVID, right? Unfortunately, this reality has been happening for a long time and will continue to disproportionately impact other Latinx individuals in the topics of access to scheduled dialysis for undocumented people across our nation, just comprehensive access to healthcare regardless of documentation status. And an area that I know I became involved in because I saw a disparity is substance use disorders. I saw that some of my patients with severe alcohol use disorder were Latinos, and they were not getting evidence-based treatment in the hospital, as well as if they needed a liver transplant due to cirrhosis from alcohol use, they were not always eligible for transplants. And this has led me now to help build a program in my hospital where we focus on providing evidence-based care for people with unhealthy alcohol and drug use. So I want to end with Mr. R's course. During the admission, I was able to provide him language concordant care. We confirmed his code status in Spanish and called his wife right in the emergency room so that she knew he was going to get hospitalized and probably had COVID. He unfortunately quickly became very sick and was in the ICU for over 3 weeks. But he was actually recently discharged from the hospital, spent about 6 weeks total there. His wife, unfortunately, also had COVID, and she was unable to visit the ICU for that reason and also had trouble affording her rent, but other healthcare workers actually helped her keep her housing. And then he had a left shoulder injury and has resulting weakness and numbness from this hospitalization and is worried about his future ability to work. So he's currently applying for relief aid. So I'd like to end there. Thank you so much to Kalahia and to all the other panelists for making this possible.
Thanks, Dr. Martin. Excellent presentation. It's really important, both the coverage issue and the ethical tensions that Latino physicians face really impede our ability to scale up the profession and make it attractive. Jeff, I'm going to turn to you. We have a lot of questions from the audience, so I'd love to get us all teed up for that.
Great, and thanks everyone for an outstanding job of your presentations and really making the case why we need to take action now. I guess the first question is that what would you all recommend as far as action to be taken now, given the financial climate, the health climate that we're in? I would say from the commission perspective, we had many legislators and the administration and private sector players all get rallying around these workforce recommendations. But now we're in a situation where the financial stability, the financial health of our state and of our providers are really, and the educational institutions are all in jeopardy. And as Dr. Anya mentioned, there are significant cuts being proposed to residencies, loan repayment, Song Brown, some of the things that really were working and we fought hard to do. So what would you invest in now? If you could invest in one or two things now, or encourage our audience to advocate for now in order to move the needle.
Yeah, I mean, in terms of short-term, in terms of short-term solutions or that are going to give us a return on our investment more quickly. As I did mention, DACA. I mean, that is a workforce right there that we cannot afford to lose. And the second is supporting programs like the UCLA IMG program that already have this production, ongoing production of high quality residents that are have linguistic capacity in Spanish. And so they already, you know, it's immediate bang for your buck, you know. So I would say those two are the kind of the short-term things that I would really advocate for. And again, knowing that things like Song Brown is on the chopping block. I mean, 90%, that's again, something that we just can't afford. And so there's definitely things that we can do this week. A lot of these things actually this week, this month is really what we're looking at, DACA with the Supreme Court, the Song Brown program. Again, this is stuff that's going on right now that we can really do something about.
Dr. Martin or Vargas Bustamante?
I think the other thing that I would add is that, you know, we see COVID-19 exacerbating so many disparities right now, and the response is like to cut certain things on the budget. But the most important thing is that these disparities are going to continue, and it's more important than ever to ensure that these programs, which have already the track record that you learned about here, that we continue to endorse them and to make sure that their funding is there, because this is going to mean a future workforce in the next 10, 20, 30 years.
I actually have two recommendations. One is continue to identify ways of expanding medical to the undocumented. Right now, as I understand, is going to be probably paused given the financial situation of the state, but definitely not forgetting that once the state coffers recover, this track towards universal coverage should continue. And in the meantime, I think that a very cost-effective solution to providing health services to the undocumented would be through funding to telehealth and offering telehealth services to undocumented immigrants and other underserved populations. Because right now there is a scarcity of, as Joe Ali talked about, linguistically competent primary care physicians, and telehealth could be a good way of trying to connect those patients with the providers that can address their healthcare needs. Just today, Joe Ali, LPPI published a brief from Joe Ali that talks about telehealth. So I will encourage you to go to the LPPI website, and it's just there. I think telehealth in these years of struggle and of financial hardship is going to be a good investment while we continue to expand medical in the future to the undocumented population.
So all very practical solutions. Another practical question comes from our audience. Many of the audience members are Latino physicians or medical students. They're asking, what can they do now to advocate for these issues, the increase in physicians in particular and medical students in California, but are there avenues that they should pursue now to engage in advocacy around these issues you've identified?
You know, one of the things that comes up for me is making sure that they are, you know, we've all been mentored by different people. I know that's the reason that I am here today and being able to do this, and making sure that they're able to mentor other people who maybe are a few years back in their careers, to make sure that they encourage. I know the National Hispanic Medical Association right now has a program focused on people who may not have easy access to mentors, and linking different healthcare providers with them so that they have a resource. And I think this will help encourage people to stay on the path, the healthcare career path that they want, because oftentimes people get discouraged. I know, you know, I took one organic chemistry class and I took a year off from my, you know, pre-med course, and I'm just glad that I got back in because someone believed in me. And so we all need that.
I'll also say that there's a Latinx Physicians of California that folks can get involved with. There's also Health Workforce Policy Coalition led by CPCA that actually today is having a major action around contacting legislators and tweeting about the importance of investment in health workforce and diversity related issues. And so perhaps we can send out some of those that type of information to the audience for people to engage. I think given the time, maybe have one last question, which is around how we might incentivize medical schools to admit more people who are bilingual, who have language capabilities. Anything that you would suggest to help provide that incentive?
Yeah, I do think that unfortunately may be financial, and I know that we are in a difficult time for that. But even as you support things like the pipeline programs that are essentially raising these students, that in and of itself is incentivizing. And so supporting these pipeline programs at these institutions really does incentivize in that indirect way, because we need these students to be successful once they get there. The last thing we need is for our students to be making it in and then just not being able to keep up. And so we need to prepare them. And if we invest in these programs, we can indirectly incentivize them while we are, able to more directly incentivize them.
Any last thoughts before?
I was just going to say, and to add to that, I think just like thinking about the health costs and savings that are associated with having language concordant care eventually, right? Because of training, investing in Latinx physicians. And so trying to show some of that data and find a way to incentivize medical schools, especially the UC system.
And I'll kind of end off, and one of the reasons Cal IHEA is working so closely with Jeff Oxendine and is he's a great guy, but also that the Workforce Commission has recommendations we can look to and lean on that were consensus by experts in the field. And if we can refer to those recommendations as we continue our advocacy efforts, we don't need to recreate the wheel. The solutions are prioritized in there. So I think those of you on the phone, please get to know the Workforce Commission, Future Workforce Commission report, and advocate. Call your legislators, remind them about the priorities of the report, and let's not recreate the wheel. We have a good set of solutions that'll take us there. And I think we need to double down and put pressure on both the governor, but also your legislators. So there are things that you can do. Thank you all for your time, and thank you all for the great presentations. We have a lot of work to do to solve this problem, but I think with all the energy here, I'm confident that we'll make a difference. Thanks so much for your time.
Thank you.